Good morning, everyone, and welcome to another morning of Grand Round. So Dr. Courtney Thomas is going to be speaking this morning. She's joining us from the University of Texas Health and Science Center in San Antonio. Some of you still remember Fachan Lee very, very well, our former colleague. So he works together with Courtney right now. He recommended Courtney to us as an excellent speaker. So we are so fortunate to have her with us. So Dr. Thomas did a medical Doctors of Osteopathic Medicine, which she finished in 2012 at the Midwestern University College, Chicago College of Osteopathic Medicine, Downers-Grove, Illinois. That was after she had completed a master's degree in biomedical sciences, also at the Midwestern University. Between 2012 and 2013, she did a traditional rotating internship at the Lake Erie College of Osteopathic Medicine in Florida, and went into residency at the North Ohio Medical University Summer Health System in Akron, Ohio, where she completed her APCP residency in 2017. She followed that with 2 fellowships. The first one is Search Path at the Hartford Hospital in Connecticut. And then the second fellowship is in a topic that is one of my favorites, which is gastrointestinal pathology. This was at Yale University School of Medicine, New Haven. She finished that in 2019. Since 2019 to now, she has been an assistant professor at the UT Health and Sciences Center, San Antonio, Texas. And I'm sure that she and our Dr. Yan Dean also overlapped at some point right there. So Dr. Thomas has presented her work on smooth muscle tumors and staging of resectable distal pancreatic cancer at USCA. And she has published a variety of articles also on pancreatic cancer and tumors of the GIT. But today she's going to be talking to us about liver tumors, and her topic is updates in molecular and pathologic features of hepatocellular carcinoma. So thank you again, Dr. Thomas, and over to you now.
Thank you for the introduction. I'm happy to be here. Yeah, this is my topic. And let me make sure this is working okay. Okay, so I have no financial disclosures, no disclosures at all, really. So just I guess a summary of why I'm interested in this topic. I mean, obviously I'm a GI and liver pathologist, and I was asked to give a talk, a similar topic to hepatologists and surgeons in San Antonio. And they wanted to explore this molecular changes and in hepatocellular carcinoma. And as we all know, people are ordering more and more NGS and KRAS testing very frequently on tumors, and that includes now we're seeing an uptick in our clinicians ordering them in hepatocellular carcinoma. So it was really a good way for me to educate myself. I am not a molecular pathologist, so this is going to be kind of a basic for what the surgical pathologist needs to know to understand some of these findings. So with that said, the few things I'm going to talk about are the molecular alterations that we know of so far in hepatocellular carcinoma, the histologic subtypes of hepatocellular carcinoma. So I'm not sure how many people really know the extent of subtypes that exist that are published in the WHO. So I'll talk a little bit about the ones that seem important or that have molecular alterations, and then a little bit about the possibility of liquid biopsy and diagnosis and monitoring of HCC. So I'll just start with a case. This actually was a case we had on a tumor board a couple of weeks ago, so pretty recent. So this is a 71-year-old female. She had a history of hep C cirrhosis, which was treated with Epclusa, and she had a sustained viral response. So good response to the HCV treatment, still with cirrhosis. She was well compensated, so everything seemed to be going well. But she has on surveillance imaging, they found a LIRADS5 lesion in segment 5-6. So for those of you, I'm not sure, not everyone uses the LIRADS system for radiology, but that's essentially a way for radiologists to say if it's a definite HCC or, indeterminate lesion and whatnot. So when they call something a LIRADS 5, it essentially means that they're sure this is a hepatocellular carcinoma. So they really don't need to biopsy this. So they have diagnosed it as a HCC essentially on imaging. And the tumor markers, the alpha fetoprotein level was 9.3, which in our lab is normal. And this person, after tumor board discussion and discussion with the patient, she elected for a partial hepatectomy to remove the tumor. And so what we have here is her partial hepatectomy. And on gross exam, we have essentially one larger nodule, but there's a couple satellite nodules. So the larger one has like a yellowish brown appearance, and the satellite ones have more of a tan or paler color in appearance. So it could be a multilobulated single nodule or a multiple satellites off of the primary tumor. And on H&E stain, we have the tumor here, which we have the sheets of hepatocytes. There's another area that has like a little bit of fibrous band, and then there's a separate kind of satellite area of tumor again. And so even on low power, we can see that the trabeculae here are very thick, and it has somewhat of a nested architecture. So atypical architecture already with a LIRADS 5, consistent with HCC. And on higher power, what we have is a kind of a variety of appearances. So we have some nesting and maybe a hint of a pseudoacinar formation. So this like little trying to form a gland or acinar structure is what we mean by pseudoacinar change, which is a feature we see in hepatocellular carcinoma. And also, while it's a little harder to appreciate the trabeculae on here, this one might be a trabeculae, which looks a little thick, but maybe still 2 cells across. And in this one, we have a much thicker one, maybe like four cells across. Another area of the tumor, we have a somewhat different appearance. We have steatosis. So this is the macrovesicular steatosis here. And other areas, we have this very dense, ropey Mallory dank bodies. So there's a lot of Mallory's hyaline in here and the fat. So there is some component that looks like steatohepatitis as well to the tumor. And reticulin stain, just to highlight the architecture and confirm our diagnosis of HCC. So here we have, again, a little bit of nesting. It doesn't have the nice, hepatic cords that are 1 to 2 cells thick. So we have a weird kind of reticulin architecture here, which helps us confirm that it is indeed a hepatocellular carcinoma. And this is the other area that was not so steatotic appearing, but we can see that abnormal architecture with the reticulin. So this was called moderately differentiated hepatocellular carcinoma with steatohepatitic features. So this is this steatohepatitic form of hepatocellular carcinoma is one of the subtypes I'm going to talk briefly about. But we can see that this one had a little bit of a biphasic kind of architecture where you had one of the more conventional ones, and then you had the satellite tumor that had the Mallory's hyaline and the steatosis consistent with steatohepatitis features. So this is showing the new WHO, or the most recent one, has about 8 subtypes listed for hepatocellular carcinoma. One of them includes the steatohepatitic form. There's also clear cell, macrotrabecular massive, serous, chromophobe, fibrolamellar carcinoma, which maybe we know a little bit more about, and neutrophil rich, and then lymphocyte rich. So of all of these, the ones that have molecular changes that are characterized in these tumors are steatohepatitic, macrotrabecular massive, serous, chromophobe, and fibrolamellar carcinoma. So the purpose of my talk is to talk a little bit about these and what their molecular signature is. And I took this from the WHO as well, so it just shows you the subtypes, and then the key molecular features. Is a nice summary in the WHO book that they provide. And also they have prognosis. So one of the ones that's important that I learned about earlier was macrotrabecular massive is associated with a worse prognosis. So it is important to maybe identify those earlier on, as those people tend to have a worse or progression-free survival, or they might recur after resection or even transplantation. Okay, so the TCGA, the Cancer Genome Atlas, which publishes widely on various tumors, has put out this data, which is very complex looking chart on a hepatocellular carcinoma. And what we can kind of see just from basically looking at this, trying to break it down into fundamental, is what the mutation that's most common is TP53 and CTNNB1 seem to be the more common ones. And you also have deletions in CDKN2A, RB1, and P10. So some of these other genes. But as you can see here, there's a ton of other genes that are maybe mutated in HCC. So it's very heterogeneous mutation profile. And I think that speaks to the heterogeneity of the morphology on HCC. So we have all those different subtypes. And I think that goes along with how many different mutations we can see. So one of the things that came out of this TCGA data was that they found the TERT promoter mutation. So it's a telomerase promoter mutation in about 44% of the hepatocellular carcinomas. And in these patients, they tended to be older and male. And this was more likely seen in patients with hepatitis C and less likely to be in hepatitis B. And then the importance of this mutation is that the TERT promoter is involved in tumor initiation and malignant transformation. And it also may co-occur with CDKN2A silencing mutations. And so this leads to a downregulation of the P16 INK4A gene and allows for cell immortalization. So this is kind of the basis of maybe some tumor initiation up front. And this was paper showing that that phenomenon, I guess. So they're looking at patients with cirrhotic livers, but no tumor. And then they look at people that have low-grade dysplastic nodules, high-grade dysplastic nodules, and then HCC. And what they see is a kind of a stepwise progression of acquisition of this TERT promoter mutation in people that have dysplastic nodules, and then increasing until you get to hepatocellular carcinomas. So this kind of confirms that this is an important step in malignant transformation for HCC. And then in terms of viral hepatitis associated mutations, so viral hepatitis, very common. We see a lot of hep C, maybe not as much hep B, but it's still pretty prevalent depending on where you practice. And between these, they found that TP53 mutations are more likely in hep B positive patients, but TERT promoter mutations are less likely. And conversely, in hep C, the TERT promoter mutations are more common, as are the CDKN2A promoter silencing mutations. So I know this is all a little bit kind of in the weeds a little, but as we get more and more data on these, we might be able to tell which ones are actually relevant to diagnosis and or treatment. So additional driver mutations were kind of broken down into the area that they alter in the genetic pathway. So the TERT promoter is for telomere maintenance. The cell cycle genes, we have the TP53, which is commonly mutated in many tumors, not just HCC, but also RB1 and CDKN2A. The Wnt beta-catenin pathway with the CTNNB1 mutation is something that we probably see more commonly now as we're getting people, the clinicians are recognizing that beta-catenin mutated adenomas are more worrisome for them. And so those might be more inclined to be resected. So this is a stain we're doing now is beta-catenin on most of our adenomas just to confirm that they don't have any beta-catenin mutation. And then other things in oxidative stress, epigenetic modification, and then the AKT mTOR MAP kinase pathway, and those things are including VEGF-A and the TSC1. Okay. So in advanced HCCs, what we're seeing are fewer of those beta-catenin or the CTNNB1 mutations, but more frequently TP53. And we'll see later that this is especially relevant to the macrotrabecular massive type of HCC, which has more frequent TP53 mutations. And these probably are the ones that are more common that I've seen on the NGS reports I'm getting back now. So in terms of TP53 mutations, there's another good paper that kind of broke down a lot of these findings into their histologic, also their histologic findings. And so patients that had TP53 mutated hepatocellular carcinomas more often have both macro and microvascular invasion. And then they also are higher histologic grade. They may have sarcomatous changes and pleomorphic cells, and they're associated with a macrotrabecular massive phenotype. So those are all like features of, higher grade, more aggressive tumors. Whereas in the TP53 mutated tumors tended to have less cholestasis, which, cholestasis and maybe like pseudoacinar change are usually seen in like lower grade HCCs. And for the CTNNB1 mutations, those tend to be more in well-differentiated cholestatic HCCs. So here's a gross photo. We have that greenish appearance where the cholestasis might be more prominent. And we can see that on the H&E here with those like pseudoacinar formation forming bile. And on the beta-catenin stain, which is a marker for this mutation, we see nuclear staining. So the abnormal staining pattern for beta-catenin is nuclear. The usual thing you'll see in non-mutated is membranous or cytoplasmic type of stain. And then glutamine synthetase is GS. So in hepatocellular carcinomas, they're usually if you do a glutamine synthetase stain, often they'll be diffusely positive, and that's kind of what they're showing here. And again, for the characteristics of these CTNNB1 mutated tumors, we see that they are somewhat larger in size, so greater than 5 centimeters, but they have an intact capsule, so maybe like a well-circumscribed lesion. They're usually lower histologic grade. They tend to have more, smaller trabeculae and pseudoglandular formation, as we saw here with cholestasis, and less likely to have inflammation. And then again, we have nuclear beta-catenin stain, and they express glutamine synthetase more diffusely. Okay, one of the things about CDKN2A mutations that they found also is a higher risk of tumor recurrence and poorer survival overall. So there's a chart here that looks at all of these, factors. So whether it's male, gender, alcohol, and then all of the histologic or pathologic findings of these. And it can show that there's, this very positive association is this dark red color. And so for these various genes, one of the things on CDKN2A is its high level of recurrence, maybe more associated with alcohol, but not as significant. And so generally speaking, they have a lower overall survival because they have more incidence of recurrence. Okay, and now for steatohepatitic variant of HCC. So these are usually seen in patients with a history or a background of steatohepatitis or metabolic syndrome. Not always. I mean, you can have a patient that has, not a significant fatty liver, but they also have like a hepatocellular carcinoma that has steatohepatitic features. Also, as in our patient case earlier, they're associated with chronic hep C infection. So we know that people can have, two things happening. They could be infected with hep C, and they can also have fatty liver disease, or certain genotypes of hepatitis C, I think it's genotype 3, tends to have more of a risk of steatosis just by means of that viral genotype. And so on here, what the steatohepatitic HCCs show are, usually not as many satellite lesions. They don't really have much vascular invasion, and they lack the CTNNB1 and TP53 mutations, as well as the TERT promoter mutations. The interesting thing about these that they found is they have a high rate of C-reactive protein expression on IHC, and that is, they found that to be due to or correlated with the IL-6 JAK-STAT pathway activation, which is one of the characteristics of this type of subtype. And in general, they don't have those same, TP53 and TERT promoter mutations. And as I said, they lack the satellite nodules and microvascular invasion. So maybe they tend to be a little more indolent, not super aggressive tumors. All right, the serous variant of hepatocellular carcinoma is not very common, so only about 5%. But these are the ones where you have kind of more atrophic appearing tumor cells or entrapped in this very dense hyalinized stroma. And the stroma is a very prominent feature, so about 50% of the tumor can be occupied by this stroma by itself. And these are more aggressive than the usual conventional hepatocellular carcinomas. So again, it might be useful to subtype these as they may have a worse overall survival. And because of the nature of this dense collagen deposition, the histology overlaps with fibrolamellar HCC, which is the differential here. And in serous HCCs, what they've found is TSC1 and TSC2 mutations, which has been involved in the PI3K AKTP pathway. And so they actually have now inhibitors for that pathway. So this could be relevant because if they have a person with a more aggressive course, they can potentially use these targeted therapies to help control this disease. And one of the important things on IHC that we can find is it usually expresses cytokeratin 19. And that's a little different from what we see in fibrolamellar. So this could be an important stain to help you to help you rule out fibrolamellar. Okay, so fibrolamellar HCC, since I was talking about that in the differential, these are usually younger patients. So in contrast to serous HCCs, those are usually older or middle-aged people and cirrhotic livers. Fibrolamellar is usually younger people or kids, and they arise in non-cirrhotic liver more commonly. And they may have a normal AFP or only minimally elevated. So, also one of the characteristic findings that may be seen on imaging is a central scar. So in the picture here, we have a resection, and that you can see the background liver is pretty normal. We don't see any nodularity or cirrhosis. And the tumor here has irregular border, and we have this central kind of white fibrous scar. So that's pretty characteristic of what you hope to see grossly in fibrolamellar HCC. On histology, what we have here is kind of similar to the serous. We have the dense pink fibrosis in the background, but the tumor cells are somewhat different from serous HCC in that they're usually more plump and eosinophilic. So we have bright pink eosinophilic cytoplasm. They tend to have prominent macronucleoli. So all of these nucleoli are pretty prominent. And they may have like pale bodies is another thing, which I don't see a good picture in here depicted, but the macronucleoli, these thicker eosinophilic cells, are pretty characteristic of fibrolamellar. And what the staining profile, they stain with CK7, and then CD68 may also be positive. So those two are unique. But the thing that is probably most diagnostic of fibrolamellar HCC is if we do the FISH testing for this DNA JB1 PRK ACA fusion. And this, if we have this fusion protein, it's essentially 100% specific for fibrolamellar HCC. That's like the classic kind of teaching. And if you have like a board exam question and they have this fusion, that's diagnostic of fibrolamellar. And that leads to an overexpression of protein kinase A. So testing for that, and especially in a younger patient, is key to diagnosing or confirming your diagnosis of fibrolamellar. And just to show a little bit of the histologic overlap of the serous variant of HCC and then the fibrolamellar variant, again, we have very similar appearances on low power. On high power, you can see that the fibrolamellar, though, has that a little bit more prominent eosinophilic cytoplasm and nucleoli compared to this one. But again, you can do the FISH testing, and also the cytokeratin 19 is a good way to differentiate the fibrolamellar versus serous. As in one of these papers, they found that really the cytokeratin 7 will stain pretty much all of the fibrolamellar, but even like up to 88% of the serous. So that's not a good marker to differentiate those two. But the cytokeratin 19 was not found in any of the fibrolamellars, but also maybe not great because it was only in about 50% of their tumors in the serous variant. So that is probably where it becomes important to do the NGS testing, because if we have those, that the DNA JB1 fusion for fibrolamellar, that will be good, and then to exclude the serous variant. The macrotrabecular massive form of HCC. So these ones are interesting. I haven't seen a lot of them, maybe a couple, but there's literature that describes them in somewhat differently. So the WHO says they have to be trabeculae that are greater than or equal to 10 cells in thickness. I've seen in some papers 6 or more cell, in thickness, but either way, you shouldn't really have to count across. It should be pretty prominent that they're very thick. And I think here we can notice how thick these are. Again, it's hard to count because there's some overlap here, but this is what you would be seeing on your H&E stain. And for the macrotrabecular massive, these patients have a much higher AFP level. They're often have more satellite nodules, and more often have macrovascular and microvascular invasion seen compared to the non-macrotrabecular massive variants of HCC. And then these ones also have those TP53 mutations. They have a little bit more of the FG19 amplifications, but the key thing here is that they're more aggressive, they have higher AFP, and they have early relapse, and disease-specific survival is poor. So here they're looking at the survival chart, or I guess the relapse here. And compared to the non-macrotrabecular massive types of HCC, they find that there's a significant change in terms of time to relapse. So they seem to relapse much earlier, and they have also a poor overall survival. And I think that's why this is important to recognize. Okay, so the last, I guess, bit of my talk would be a little liquid biopsy and its potential. And again, I'm not a molecular person here, but I find this kind of fascinating and exciting to see where we can take this, for people with the future of HCC. So For the importance of biomarker testing, which I've maybe talked a little bit about earlier here and there, is to identify patients with advanced disease or those that have potential therapeutic targets. So as more and more, genes are found and they're able to make, drugs that target those genes, these are becoming more relevant. So especially if people that have good response initially and then they relapse and they're no longer responding to their chemotherapy, I think it's important to find these potential targets so that they can be treated and not have widely metastatic disease. Also, one of the things would be assessing therapeutic response. So if we have a simple test that can be used to assess for how the tumor is doing, sometimes they do like the CEA level in patients with colon cancer or whatnot. And if they see like a bump in the CEA, they're worried about recurrence somewhere. Something similar to that would be, important in any tumor really, but HCC for my talk. And the presence of high tumor mutational burden correlates with their response to the immune checkpoint inhibitors. So if they exhaust their initial first-line therapy and they find that this patient has high tumor mutational burden, they can actually try the immune checkpoint inhibitors as a second line. So some of the challenges, as we saw in that TCGA graph, there's a ton of different gene mutations seen. So the complexity of the findings in HCC is very broad and complex, right? So there's also the different subtypes of HCC. Some of them are maybe not as aggressive as others, and so it might not be key to recognize or identify those, but others, namely the macrotrabecular one and other ones that have targetable mutations can be important to identify. And another thing is we often don't get liver mass biopsies for confirmation of HCC as they are when they're screening the patients at risk of developing HCC. So like the cirrhotic patients, they have that LIRADS criteria. So often they can diagnose hepatocellular carcinoma on imaging characteristics and they don't require biopsying those. So we may actually have less opportunity to do our testing as we just don't have the tissue. And that is where maybe the benefit of the liquid biopsy comes in, is where we don't actually need tumor tissue or a biopsy. We just can do a simple blood draw. And for, a brief overview, kind of for dummies in a way, the non-molecular pathologist. So the summary in the preface of the liquid biopsy is we have, our cirrhotic liver here, and we have our tumor, our HCC. And so the tumor will give off pieces of, DNA, or circulating tumor cells will kind of break off and go into the bloodstream. So here we have, our circulating tumor cells. We have cell-free DNA or circulating tumor DNA. They may have extravesicular or extracellular vesicles, or these little vesicles that can also be detected. And, they have these methylation or epigenetic modifications they can test for as well. So all of these components, if they're looking for when they do their blood draw, can tell them something about the tumor in the blood. So the benefits of this would be, minimally invasive. It's a blood draw. There's many times where we need more tissue, for NGS, and that requires the patient maybe to be undergo anesthesia and an invasive procedure. So the liquid biopsy would really be, very useful in these patients. The potential for earlier detection of cancer. So in hepatocellular carcinoma, they use alpha fetoprotein level and ultrasound for screening. But if they can also use this blood test, it might, increase the ability to pick up people earlier, and then therefore give them a better chance at, tumor treatment. It can also be used for monitoring treatment response. So maybe someone is doing well initially, but then They may have an increase or a relapse that they can then test for. And then that's, again, with the same thing with tumor recurrence is maybe periodic blood draws to do liquid biopsy looking for residual circulating tumor cells or things like that. So this is just kind of a nice picture of all those things. So if they use the liquid biopsy for the initial diagnosis or screening, they can do that. They can do some molecular profiling on there. And maybe that will tell them something about the biology of the disease or if there's any high tumor mutational burden or something like that, they might be able to find that out earlier so that they can tailor their treatment to that. And then once the patient's been treated, if they're doing well, and then maybe they have a spike in their AFP level or something, they can do more liquid biopsies and repeat the process looking for mutations and things that maybe weren't picked up earlier, and kind of monitoring the disease response as they change their treatments. So a couple of things that I found related to HCC is that the circulating tumor DNA, this is ctDNA detection, that in patients that had prolonged response to immune checkpoint inhibitors, they may identify those with residual disease or risk of progression. So if people have been on immune checkpoint inhibitors for a long time, but they still have some circulating tumor DNA, that means that there's some, obviously tumor that's not being, killed off or in check with the treatment. So they may have, higher risk of disease progression, and that might be helpful to know up front if they can add additional agents or tailor their treatment. And then also the DNA methylation studies have found many markers in HCC that have pretty good sensitivity and specificity. And there's several listed here that they've found as being good markers for the DNA methylation. And so this DNA methylation study in liquid biopsies can be useful upfront to screen for hepatocellular carcinoma in these high-risk patients. And then another one of these papers had a nice kind of summary of all of the things that have been seen so far. And again, as we said, correlation in circulating tumor DNA can be useful in patients on the anti-PD-L1 drugs, and also the tumor mutational burden on the circulating tumor DNA can be used to identify those people that are maybe more susceptible to immunotherapy and have a better response. Versus higher levels of the CT circulating tumor DNA at baseline had a better, better response. So if you have, a higher tumor burden initially and you're treated with immune checkpoint inhibitors, they tend to have a better chance of complete treatment or complete response. So the way that they can use the circulating tumor DNA is initially looking at the tumor before treatment and then the circulating tumor DNA after treatment or during treatment. And if the circulating tumor DNA is negative, in about 70% of patients, that means a complete response. So this is useful, obviously, to make sure that their treatment is working. And then the hypermutated circulating tumor DNA, it was associated with favorable outcome, including 3 HCC patients, and those were treated with different immune checkpoint inhibitors. So, basically all of this is to say that, we have good markers of that can predict response or people that are at risk of poor response. And that is important in, treating the tumor. Okay. I think that was pretty much most of my stuff. So in conclusion, we have, numerous mutations and subtypes of hepatocellular carcinoma. They involve various pathways, and those pathways seem to be associated in some cases with different histologic subtypes. And then some mutations are more associated with aggressive clinical course, namely the TP53, being with the macrotrabecular massive phenotype. And so those are the patients you might want to identify as patients that have hepatocellular carcinoma that receive a transplant. If they have some of these mutations, they might be higher risk of recurrence or metastasis after the transplant. And it might be helpful to know that before transplanting them. And then the mutations identified can lead to differences in screening for recurrence or progression, and also the treatment. So liquid biopsy can prove useful in the future for diagnosis and monitoring of HCC, particularly because we don't always get, biopsies for HCC based on the imaging characteristics. So with that, I think that's it. Maybe I finished a little bit faster than I anticipated, but yeah, thank you. Any questions?
Thank you very much, Dr. Thomas. That was a very good overview of hepatocellular carcinoma and some of the molecular things. It's very clear, as you speak, that HCC is still very, many years behind a lot of other solid tumors when it comes to molecular characterization. And I think one of the reasons is because of the diversity and the absence of one particular or any particularly recurring genetic changes in HCC. So one of the questions that I've always had, and I'm just going to ask the first question before, all this genetic and especially the morphology characterization based on biology and everything, how do you think, how useful in the clinical setting do you think they really are? So let me clarify. When I look at the liver biopsy for HCC, and sometimes when I see the macrotrabecular, I tend to point it out just to get them to do something quickly. But when those tumor comes out, you find out that the macrotrabecular might just be 5% of the whole tumor. And in the same lesion we're speaking of, you pretty much see every variation of what you just showed, the steatohepatic, you see everything. So I'm just wondering how useful it would be just to try to predict based on a needle biopsy. And even when you get the resection, you already have the tumor. And at that point, the staging and the completion is the only thing that is important in terms of outcome. So now we have all these different morphologic variants. How have you used them, in clinical setting to be helpful?
Yeah, so that is an important point. I mean, a lot of these, because we have histologic, or pathologic findings, so the steatohepatitic one will look steatohepatitic. So we don't need to look for, that JAK-STAT activation or do like a CRP stain, because we actually don't have CRP expression. So it's just based on morphology in your H&E stain. And then the macrotrabecular massive, yeah, it's on the needle biopsy. If you have that sampled correctly, you can identify that and put that in that it's associated with more high risk features or poorer prognosis. But then if it's just a small part of the tumor, it's kind of like, what does that exactly mean if it's only like 5% overall and they resect it? And I think that might be where the NGS possibly could be useful, is if they identify that TP53 mutation, even if it's a small amount, and they can say that that's a higher risk, maybe they can, tailor something or surveillance more frequently if they get a resection or a transplant. And I know sometimes if they have a very aggressive tumor, they don't like to necessarily transplant the people that they know are going to recur very fast or metastasize. So that could be, useful to them. Otherwise, I think part of the reason why this is kind of lagging in HCC is there's not any, like breakthrough, findings on NGS that we couldn't tell them initially on morphology. So Really, it's if they have anything that, that AKT mTOR pathway that they can target later, in which case they'd probably rebiopsy and then send for NGS to find these. Or if they need a PD-L1 inhibitor, that might be more relevant to clinically. The one that I found more useful is the beta-catenin, which we do in every, adenoma, if we can't tell if it's, a benign acting adenoma or if it's maybe more on like a well-differentiated HCC. They really want us to do the beta-catenin stain. And I think that is more useful in identifying, beta-catenin mutations upfront, and those are the ones that they might be more inclined to resect is what we find here. But hopefully that answered kind of your question.
Yeah, it does. Thank you. So do we have other questions from the audience?
Yeah, this is John Eckfeld. I thought it was a very interesting talk. I'm basically a clinical chemist, so I don't look at surgical biopsies or do gene testing, but I was always under the impression that alpha fetoprotein was better, but when, from your data and I Googled and on my phone, only about 60% of patients have elevated AFP, while a very high AFP is pretty diagnostic for hepatocellular carcinoma. It's really not a very sensitive test. Sort of another question, you may not really know the answer to this, but hepatitis C is basically curable now, that's my impression. And I thought there was some initiative by Health and Human Services or something to get these patients treated. Do you know anything about where that stands? I see your patient had Hep C.
Yeah, I think they are treating more people with that Epclusa. I think it's still very expensive, and depending on your patient population, we are in an area where we have a lot of unfunded patients, so it might be a little harder to get approval for those drugs that are very expensive. But the Epclusa and the newer therapies are very, very good at treating Hep C, but they still have propensity for HCCs, and they still may have cirrhosis. They do have like a phenomenon of regression of fibrosis sometimes, so they may eventually go from like cirrhosis to maybe bridging or a little bit less, but they still have advanced fibrosis and a propensity, or increased risk of HCC. So they still need to be screened appropriately. And I can't remember the test, the blood test, but there is a better test, but there's another blood test for, instead of AFP, but for monitoring. I think it starts with a D, which I can't remember the name off the top of my head, but I think the clinicians are starting to request that. And I think it must have been presented at a recent, course, that their abstract presentation, someone mentioned that clinicians are now knowing about. So I'm not sure, that might be picking up more of those AFP negative HCCs.
Okay, thank you.
I mean, if I may just add briefly to that, in some ways, it's true that AFP is quite specific, but in more ways, it is completely untrue. The tumors that are likely to give you more AFP are actually not HCC. So most HCC patients now, unless you are dealing with the very, very poorly differentiated huge tumors, when AFP is elevated, it's usually like under 100. So when you start getting AFP of 500, 1,000 from HCC, it essentially is very bad. Transplant people will not even touch it. That's how bad that is. But when you see that level, depending on the clinical context, you have to start thinking of, if it's a young child, definitely you think of hepatoblastoma, which is more likely. If it's younger people, adults, then you have to start looking at germ cell tumor. You have to start looking at other things. In adults, you want to start looking at things like pancreatic carcinoma and a lot of other things. So AFP as a screening for HCC has really not performed as we would like it to perform over the years. Having said that, if you start with a tumor that is producing AFP, then AFP becomes an important monitor for recurrence and things like that in that particular context. But there are more tumors that are actually more likely to cause high ALP than hepatocellular carcinoma, unfortunately, in those contexts. So we have about 10 minutes. I don't know if the molecular people are still there if they want to just chip in about the issue of liquid biopsy in HCC, but I guess it's probably being used in other things. And I think Dr. Thomas really raised a very good, point about what this is going to look like in HCC.
Dele, you want me to take the bait?
I was hoping you would.
Hi, Courtney. Andy Nelson. I'm one of the molecular pathologists here, and thanks for a nice talk. I always worry a little bit about liquid biopsy. And just for transparency here, we run tissue-based NGS as part of a larger kind of national consortium with about 30 plus other academic labs. We have not done any forays into cell-free DNA testing in-house. Most of that at our system gets sent out to Guardant. But our molecular tumor board and other stuff, we've spent a decent amount of time comparing Guardant results and tissue-based results. And I'll be honest, most of my experience is in lung cancer because that's where it's used the most. And, my experience is one of what the literature says, which is the concordance depends. In some cases, it's quite good. In some studies, the concordance between tissue-based testing and liquid-based testing is relatively good. In others, it's not so good. And so I'm kind of wondering, what your thoughts are in HCC, if you think, particularly with different types of subtypes and growth patterns of hepatocellular carcinoma, is that going to impact the performance characteristics of the liquid biopsies?
Yeah, I mean, I think over, my researching for this, it's a little skeptical what the super benefits in long-term will be. But I think because it's still like new-ish, technology, I was hoping that as things improve, it would be much better in, like 5-10 years as it goes. But for now, it's hard and they're not really, pushing for that. But I think that it has good potential, whether it's, you think about like this probably very small amounts of circulating tumor cells or DNA that are pushed into the bloodstream from these though. And it's kind of like, you wonder how much is actually going to be, testable or on the liquid biopsy. But I think it in the future, if we get better with the testing, and I'm hoping that it will improve the liquid biopsy, but
yeah, I mean, my commentary on that, though, is that I'm not convinced at this point how much of it is technology versus biology. And again, how much of it is, do we really understand the kinetics of cell-free DNA release, nucleic acid release? And again, I think that there's a lot to learn in this space that is actually independent of just how much money and how deeply we sequence and how good our UMIs are and all of the things that, enable cell-free. Meihao, I'll stop and you can get in there.
Hi, can I say something? Hi, Minhao Zhong. I'm the GU and the G1 pathologist. I'm interested in molecular pathology too. So I totally agree with both of you's opinions. I think the liquid biopsy has both challenging and the biology and technical components, and also has a complicated for the clinical utility. So for the lung cancer, we use the most common. So because sometimes they want to has the fast track to identify targetable mutation like EGFR, ALK, ROS. So probably that's not applied for all tumors. So the question for the HCC is that what we are going to use the liquid biopsy for is for the diagnosis or for the follow-up to see what's the patient burden, tumor burden, or is there metastatic potential? All these questions, so it's not unclear. In addition to that, I think the most challenging for across all the tumors that for the liquid biopsy, we need the depth. We need to cover each gene for 100,000, not compared to the tissue base. We need a much more high depth coverage. So that means if we have very large panels, the whole output will be very significant increase. So that's both financially and clinically operations is become challenging. So that's why we should have found some markers which is a very high frequency in certain tumor. I think HCC has about 50% HCC has TERT promoter mutations. So that's probably is a very good markers, but unfortunately it's only 50% of the HCC has that marker. So that's my thought. So we need to explore to find at least high yield markers for each individual tumors. But unfortunately right now, even though for the we have extensive study, we haven't reached that stage yet. Thank you.
Thank you very much, Minhao. We probably have 2 minutes for one last question, if anyone wants to take that. Okay, so but thank you very much. I don't want to ask my question about liquid biopsy because it might take us another 20 minutes. So, but thank you very much, Courtney. We really appreciate that. It was a very good overview and a peek into the future of what HCC will look like. And thank you very much. Give Fachan our regards, and hopefully we'll get to see you at USCAP next year.
Yeah, thank you so much for inviting me. It was great.
Thank you all.